Good afternoon, everyone. My colleague Mona Matthews and myself, Chris Becker, would like to welcome you to today's webinar titled MACRA Quality Payment Program Support. It is presented by the Lake Superior Quality Innovation Network, also known as the LSQIN, and the Quality Payment Program Resource Center, or QPP Resource Center. The LSQIN is comprised of three organizations: MPRO in Michigan, Stratus Health in Minnesota, and Medistar in Wisconsin, to support the Centers for Medicare and Medicaid Services Quality Payment Program with practices of 16 or more eligible clinicians. The QPP Resource Center, also represented by Medistar in the state of Wisconsin, is tasked with assisting those providers with 15 or fewer eligible clinicians. We know that you and your organizations are interested in learning more about the QPP and the assistance that is available to help you be successful. We hope that what you learned today will help you all to meet these goals.
Many of you have probably seen information regarding the Quality Payment Program, so I'm not going to spend a lot of time reviewing this information. But I do think it's important to note that that MACRA had bipartisan support and is not tied to the Affordable Care Act and is not likely to be affected by changes in the Affordable Care Act. The primary purpose of MACRA was to transition Medicare Part B clinician payments from fee-for-service to more of a value-based payment system. Medicare Part B clinicians will be rated and paid based on quality and cost performance payment models defined or referenced through the Quality Payment Program. The actual MACRA legislation is about 800 pages in length, and Chris and I are going to attempt to give you some highlights of information you may need to know to get started. There's a lot more happier with that. I referenced eligible clinicians a few seconds ago. The left side of this box is a list of eligible clinicians. You will notice that the list does not include any therapists and some other clinicians that may have been included in some previous programs. For the first 2 years, the clinicians affected will remain the same and include physicians, physician assistants, nurse practitioners, clinical nurse specialists, and certified nurse anesthetists. As noted here, this list may change in 2019. And they plan on adding some clinicians to this list. The clinicians that are currently not eligible in the first 2 years may voluntarily report and receive feedback, but will not be eligible for a quality payment adjustment. There are also some clinicians included in the left-hand side of this slide that will be excluded from MIPS. They include clinicians who are participating in their first year of Medicare Part B payments. If they are below a volume threshold, and Medicare has defined 2 different volume thresholds. One is a billing charges and the other is a patient volume. So it's either if you bill less than $30,000 to Medicare Part B or provide care for 100 or fewer Medicare patients, you will be excluded from MIPS. And you only need to meet one of these criteria to be excluded. And then also certain participants in advanced alternative payment models will also be excluded from MIPS. This slide puts the eligibility criteria into who is included. To summarize, any of the eligible clinicians that is not significantly participating in an advanced alternative payment model and meets both the 30,000 billing threshold and sees more than 100 patients, they will need to report to MIPS for performance year 2017. Clinicians can report as an individual or a group. If reporting as a group, the minimum patient and payment volume is applied at the group level. A group is 2 or more clinicians reporting under the same tax identification number or TIN. Something that I will note is that if a clinician will, that clinicians will be receiving letters from CMS indicating their eligibility status for MIPS. So if you want to go to slide. Yep. So when does this start? You can start any time between now and October 2nd, 2017. The October 2nd date is the last day of the year that there's still 90 days left in the year. Many of the measures in the various categories require a minimum of 90-day reporting period. The data you collect in 2017 will affect your 2019 Part B payments. 2017 is considered a transition year, and CMS is allowing clinicians and groups to pick their pace for participation. Clinicians and groups can choose their pace in the program. And if you look on the very left side of this slide, if we start over there, clinicians can choose to not participate. If you choose not to participate in performance year 2017, you will receive a negative 4% payment adjustment in 2019. The second category here is to submit something or test your pace. If you submit a minimum amount of data in 2017, and we'll talk about that here in a minute, to Medicare, for example, one quality measure or one improvement activity, you can avoid a downward adjustment. So this would give you a neutral payment adjustment. This next category here is to submit a partial year. So if you submit for 90 days in 2017 to Medicare, you may earn a neutral or small positive payment adjustment in 2019. Then you can also submit a full year. If you submit a full year, you can also earn a moderate positive payment adjustment or maybe even earn a bonus. Go ahead to the next. So MIPS replaces some of your familiar programs. So it replaces quality, replaces PQRS. The improvement activities are a new category in the quality payment program. Advancing care information replaces what has been known as meaningful use in the past. One thing to note here is that if you've participated in the Medicaid meaningful use program, that program continues. The quality payment program replaces the Medicare meaningful use, or on the Medicare side. Then there's also the cost or value modifier. Next slide, please. Most participants will report up to 6 quality measures. Clinicians select quality measures from a list of 271 measures. These measures can be found on the Quality Payment Program website put out by CMS. In each of these quality measures are listed there. You can search using keywords on this. You can also filter by the priority of the measures or data submission type. Improvement activities. This is a new category for 2017. The activities are designed to assist practices to make improvements in their practice. There are 92 activities to choose from, and just like the quality category, there is a page on the Quality Payment Program website where you can find the various activities. These activities are centered around, are patient-centered, and to provide better care, smarter, healthier care. The activities have been proven to be associated with better health outcomes. The activities come from CMS's request for information to identify activities, and many of the activities will help practices get ready to be part of an APM in the future. Slide 10. Improvement activities are worth 15% of your total score. The total possible points in this category is 40 points. Activities are a medium or high weight, have a medium or high weight assigned to them. If you want to go to the next. So groups with 15 or fewer clinicians or in rural or health professional shortage areas only need to attest to 2 activities. With this group of clinicians, the medium weighted activities are worth 20 points and the high are worth 40 points. You want to go to the next slide? So improvement activities are centered around some common themes within the quality payment program. And they include expanded practice access, population health, care coordination, beneficiary engagement, patient and safety practice assessment, participation in an APM, achieving health equity, integrating behavioral and mental health, and emergency preparedness are all categories, part of those. Chris will be discussing the advancing care information in a little more detail, but I wanted to point out that there are some improvement activities that are eligible for bonus points in the improvement activity category as well as the advancing care category. There is a link in this slide that will take you to information on the CMS Quality Payment Program website that will give you more information about bonus points. We aren't going to go there right now, but can review it at the end if we have some time. Clinicians and groups will attest to conducting improvement activities. This is an attestation, but you will want to keep documentation of your activities in case of an audit. And this slide lists out the different ways of reporting an improvement activity. Next slide. Improvement activity attestation, you must meet all requirements of the activity. The activity must be performed for a minimum of 90 days. You must designate a yes response on the improvement activity in inventory. Group reporting, this is an interesting thing for this first year for sure, is it with group reporting, if you have a group of 1 or more or 2 or more clinicians that are reporting as a group, only one clinician needs to perform the improvement activities for a minimum of 90 days to count for the entire group.
Thanks, Mona. Advancing Care Information, or ACI, replaces the Medicare EHR Incentive Program, which was also known as Meaningful Use. As Mona mentioned, Medicare has made 2017 a transition year for providers to get started with MIPS. One way to avoid a penalty is to submit just the base measures in the ACI category. To earn an incentive, you must report on all 5 of the measures in this category for 90 consecutive days. CMS will award 50 points to providers who achieve all 5 of the base measures that are listed on this slide. To receive the full base score, providers do not need to meet a specific threshold or percentage, but must report either a yes for measures requiring a yes/no answer, or a numerator of at least 1 for the numerator-denominator measures. Failure to meet all the requirements for the base score will earn a provider an ACI category score of 0 and preclude him or her from achieving any additional points through the performance score. And just again, the providers must meet all 5 of these base measures and objectives to achieve the base score. In addition to the measures for the base score, there are additional performance measures that will increase the ACI score. The score also increases the higher the numerator for the following: view, download, or transmit, patient-specific education, secure messaging, and medication reconciliation. You can earn bonus points for reporting these measures: immunization registry, syndromic surveillance, and specialized registry reporting. When all the possible points for the base and performance scores and potential bonuses are added, there are a total of 155 possible points available in the ACI category. To receive full credit for this category, however, a provider only needs to score 100 points. Any additional points earned above the 100 will not increase a provider's total MIPS composite score. Now, there are some exemptions from the ACI, are available for the ACI category, and in just this category, not all MIPS categories. There are no longer individual objective or measure exclusions as there were in meaningful use, such as, if a provider didn't write 100 prescriptions, they could be exempt from the e-prescribing category. applications to achieve this or to be granted this exemption must be submitted annually. The date on that is to be determined yet. And categories of hardship are similar to those hardship exemptions that were seen under the Meaningful Use EHR Incentive Program. Let's take a look at those. In order to be eligible for those exemptions, they would have to meet one of the following reasons, prescribed by CMS, and those are insufficient internet connectivity, extreme and uncontrollable circumstances, lack of control over the availability of certified EHR technology. Now, if a provider would meet one of those categories of exemption, that simply means that ACI, or Advancing Care Information, will get reweighted to 0. And the 25% from ACI will be moved to the quality category, bringing the weight of the quality category up to 85%. So keep that in mind. Next slide. So there are also some exemptions for clinicians that qualify for automatic reweighting. If a clinician is hospital-based, considered hospital-based, they'll also get an automatic reweighting to 0 in that category. Physician's assistants can qualify for the reweighting, as can nurse practitioners, clinical nurse specialists, CRNAs, and clinicians who lack face-to-face interactions with patients. And this is what I had mentioned a little bit earlier. This is what it would look like. The 25% would be brought down to 0 for the Advancing Care Information, and that 25% would be moved to the quality category. So 85% of the weighting would come from the quality category in this case. The other category that's going to be used in the future is cost, and that replaces what was known as the value-based modifier. In 2017, it's not going to be used. Data will be collected on these claims, and clinicians and organizations won't have to prepare any additional reports. CMS will collect this information based on their claims. And again, it's important to note that there will be feedback on this data, but it will not be used to determine any, the composite score this year. And here's what the 2017 scoring will look like. Greater than 70 points, providers will be eligible for positive payment adjustments and exceptional performance bonuses. Anywhere from 4 points to 69 points, there will be a positive payment adjustment, no exceptional performance payment, but no negative payment adjustment. If they earn just 3 points, they'll stay neutral in reimbursement. 1 to 2 points will result in a negative payment adjustment, and if nothing is done, that'll automatically drop the payment adjustment down to -4%. And again, these payment adjustments will be realized in calendar year 2019. And ways to get at least 3 points to at least stay neutral in reimbursement. You can, as mentioned, you can report the Advancing Care base measures. You're going to get 50 points there, so that's one good way if you're able to do that. Reporting quality measures, an individual, if they reported 1 measure, or if a group reported 15 measures, that would qualify or earn them enough points to avoid that at least stay neutral. Or reporting 1 or 2 improvement activities, 2 medium or 1 high for practices over 15, or 1 medium or 1 high for small, rural, and non-patient facing providers. And this is just a good visual of what the penalty or payment structure would look like, or bonus or penalty structure. If you look forward, in 2022, provider could be seen as much as a -9% payment adjustment if they chose to do nothing, and if they chose to, if they're doing really well, there could be up to a 15% bonus above the neutral payment.
The last topic I wanted to cover is Advanced Alternative Payment Models, or APMs. There are 2 types of APMs. There are MIPS APMs that report some measures to MIPS in advanced APMs. Advanced APM participants are excluded from MIPS. The scope of the advanced APMs for the first year is pretty narrow, and this is the real short list of the 2017 advanced APMs. In the future, the ACO that the primary care clinicians working with the IPN that one may become a next-gen ACO. If this happens, Metastar can come back and talk with the group in a little more detail about how next-gen ACOs are handled. Next slide. So the criteria for an advanced APM, they're listed here, and I think it's important to go through these because in the future, their goal is to drive more clinicians towards an advanced APM to lessen somewhat some of the reporting responsibilities. And to be an advanced APM, the APM has to require participants to use a certified EHR technology, provide payment for covered professionals based on quality measures comparable to those in the quality performance category of MIPS, be a medical home model expanded under CMS Innovation Center authority, or require participating APM entities to bear more than a nominal amount of financial risk for monetary loss. So, in summary, MACRA Quality Payment Program represents the largest change in payment to Medicare Part B in over 30 years. There are two tracks that folks can participate in: the merit-based incentive payment, or MIPS, the advanced alternative payment, and the advanced alternative payment models. Quality Payment Program website is a great source of up-to-date program education. Educational and technical assistance will be provided to both eligible clinicians and healthcare organizations. Next slide. So this is our contact information for Chris and I. We are both quality reporting specialists with Metastar. Also, there is a link to the Lake Superior Quality Innovation Network website. We do have some previous websites that are posted on this website. Also on this page is the link to the Metastar website with some other information. You might want to just go to these resources for more information.